Thank you for joining this talk on late effects of childhood cancer. I hope you can hear me. And first, I'd like to introduce myself. I'm Elaine, and I have recently joined the Irish Cancer Society as Children's Cancer Coordinator. I have a nursing background, and I have more than 25 years' experience in the area of childhood cancer. I'm here to talk today about late effects of childhood cancer, and there'll be an opportunity to ask some questions at the end if anybody has any. Just to avoid a little bit of confusion, I just want to mention a few things. I will talk about childhood cancer, and this is children and adolescents up to under 15. And CAYE, children, adolescents, and young adults will also be mentioned. And this is a term that refers to an older age group. And then lastly, late effects follow-up and long-term follow-up will also be mentioned. And these mean the same things and are interchangeable. But I just wanted to clear that up before I started. So to give you a better understanding of late effects, I will talk a little bit about cancer and children's cancer in Ireland, where it is today, and the different types of treatment responsible for late effects and how they have evolved over time. I'll go into some detail about late effects and the treatment and other risk factors. And finally, I will discuss late effect follow-up and where it has come from and to where we are today. Okay, what is cancer? Where does it come from? So the body is made up of millions and millions and millions of cells, and these cells go on to make up tissues and organs. And all these cells replicate and turn over in an orderly fashion. And for some reason, when this process goes out of control, the cells multiply and go on to form cancer. And this makes it hard for the body to work the way it should do. Cancer can occur anywhere in the body, and where it forms a lump, it can be called a tumour. And an example of that is something like neuroblastoma, which is a childhood cancer, and neuro meaning nerve, and blastoma meaning a collection of tumour cells. When this abnormal replication affects the blood in the bone marrow, this is called leukemia, and when it affects the lymphatic system, it's called lymphoma. Its other terms that are important to note are staging and genetics, and different cancers have different staging systems and different genetics, and they're all important parts of the diagnosis and treatment of childhood cancer. Where is childhood cancer in Ireland at the moment? So the National Cancer Registry in Ireland estimates that on an annual basis, approximately 140 children will be diagnosed with cancer. There has been great advancements in treatment, and cure rate has doubled since the 1960s, and this leads us to about 8 out of 10 of all children treated for cancer will be cured. So some will have a better cure rate and some will have a not so good cure rate, but on average it's about 80%. There are many different types of childhood cancer, and there are too many to list individually, and they're generally grouped into as indicated from the diagram here. You can see the breakdown. You've got leukemia, lymphoma, brain and tumours of the central nervous system, neuroblastoma, retinoblastoma affecting the eyes, renal tumours, hepatic tumours, bone tumours, soft cell sarcomas, germ tumours, carcinomas and melanoma, and then unspecified. But from the diagram, you can see that 30%, which is the blue one, and 26%, which is the brain tumours and tumours of the central nervous system, make up over 50% of childhood cancer diagnosis. Okay, so now we know what cancer is and how it's how it's formed and what the different organs it can affect. So the treatment and protocols, what are they, why they're important, and the benefits and disadvantages. So treatment protocols, these are specifically designed treatment plans for a particular cancer type, and they're diagnosis specific. They represent a timeline of the treatment and when and how this treatment is going to be delivered. They guide reassessment at certain time points, and that can alter the course of the treatment depending on the results. And they're the results of years and years of international clinical trials and research programs. So what are clinical trials? And it's a word that's used a lot in relation to cancer treatment. Firstly, these are the reason that there's such progress and advancement in childhood cancer survival rates. They're the research programs trying to identify the most effective cancer treatments, and they don't just limit to new drugs and cure, but they look at side effects, quality of life issues, and supportive treatments. They're usually international collaborations, and they're run by experts in their fields, doctors and researchers, supported by big teams of nurses, pharmacists, data managers. So they're really big operations. So the benefits of clinical trials. Firstly, you can exit a clinical trial at any point along the way. There's no obligation to stay. You have access to new treatments. You've got international experts in the field developing the protocols and assessing and analysing the data. There's very close monitoring, and it will ensure that treatment for future patients is improved. There are some disadvantages as well. So new treatments may not prove to be as better than standard treatment. There may be unexpected side effects, and there also may be the burden of extra tests or hospital visits on an already challenging experience. But ultimately, the aim of clinical trials are we're looking for the best result with the least amount of side effects for this cohort of patients. So the treatment. So I mentioned the treatment protocol outlines the types of treatments, and this refers to chemotherapy, radiotherapy, surgery, bone marrow transplant, and immunotherapy. And I'll give you a little overview of each of the one and how they impact late effects. So chemotherapy is probably the most well-known form of treatment, and this affects the fast dividing cells in the body, and these include the cancer cells. And the difficulty is that chemotherapy doesn't differentiate between cancer cells and normal cells, and that's why there can be quite severe short and long-term side effects to chemotherapy. It can be given in different routes. It can be given orally, intravenously, intrathecal, and into the muscles and tissues as well. But don't be fooled. Regardless of the route, all chemotherapy is toxic and causes side effects. So we've got radiotherapy as well on the right-hand side of the screen. Radiotherapy is used to treat cancer by using high-energy X-rays to destroy cancer cells. It sometimes can be used on its own, or it's generally used in conjunction with other modalities. Total body irradiation is used as part of conditioning for bone marrow transplant, and all radiotherapy requires detailed planning. This is because the radiotherapy can cause damage to the healthy tissue and organs in the surrounding radiotherapy field and go on to lead to long-term complications. There's proton therapy is also another type of radiotherapy. It's more specific and precise with less side effects. Unfortunately, it's not available in Ireland, and it can often be difficult to access. Surgery. Surgery almost always plays some part in a cancer diagnosis. It could be something like a biopsy for diagnosis. It could be insertion of a central line for the administration of chemo or supportive care, like blood products or antibiotics, or TPN, or it could be resection or removal of a tumour. Like all surgery, there are risks involved, whether it's big or small. And again, unfortunately, there's sometimes life-changing consequences to a cancer-related surgery. I'll mention transplant. Although not everybody requires a transplant, sometimes it is part of a treatment protocol to treat certain types of cancers, childhood cancers. That could be something like a refractory leukemia, or it could be part of a treatment protocol like for high-risk neuroblastoma. And this is where high-dose chemotherapy is administered with or without radiotherapy, and it is followed up with stem cell rescue. It can be autologous or allogeneic. It's a very high-risk treatment and can result in many short and long-term complications. And finally, I'll mention immunotherapy. Now, this is probably will go on to be the one of the main pillars of treatment of childhood cancer in the future, but it's still in its infancy really at the moment. Immunotherapy is where the body's own immune system is modified so that it can identify and kill cancer cells. And how it works, depending on the cancer, a drug attaches itself to a particular part of a cancer cell and triggers immune reaction, going on to destroy the cancer cell. There are multiple clinical trials relating to immunotherapy, trying to progress this form of treatment. They are high risk as they're a new form of treatment, and hopefully they will have less side effects in the future. However, it's a new enough modality, and it remains to be seen what sort of long-term side effects will evolve in the future. So this brings us on to late effects. So although there have been great successes of cancer treatment and increased survival, it's not without a cost. Research would tell us that 60% of survivors will experience one or more late effects as they progress into adulthood. Major organs and systems may be affected, leading to lifelong health implications and ultimately impacting quality of life. So, although there are many survivors of childhood cancer living in Ireland, little has been documented about the physical, psychological and social impact of their cancer treatment. We do know from international studies that the impact of cancer treatment on survivor over their lifetime is significant. I've split this into physical and psychosocial. So physical, survivors of childhood cancer can experience a broad range of physical late effects from their cancer treatment. This includes, but is not limited to, cardiac disease, infertility, visual and hearing problems, thyroid disease, growth deficiency, and secondary cancers. On the left of the screen, there are some of the most of the systems that can be involved, and you can see it's significant. I'm not going to go into each one because there are too many to mention, but I'll give you a minute just to have a read of what's there. It's not only a physical impact childhood cancer treatment has, there's also the psychosocial impact. From our experience, the treatment of cancer, this group can be more vulnerable to mental health issues. Some suffer from higher levels of psychological distress and anxiety. From a social perspective, some survivors struggle with peer relationships and have difficult family dynamics. They may underperform academically due to misschooling and treatment effects. And this can go on to predispose them to employment barriers and financial difficulties later in life. Due to unmet information needs, survivors may choose high-risk lifestyle, smoking, drinking, taking drugs, poor diet, and engaging in high-risk sexual behaviour, putting them at risk of secondary cancers in their adulthood. We also know that they are more likely to be hospitalised during adulthood than the general population. I have a short case study just outlining some of the difficulties patients can experience following treatment for cancer. When John was 10 years old, he was diagnosed with a malignant brain tumour. Curative therapy required treatment with surgery, radiation, multiple cycles of chemotherapy, and stem cell rescue. Prior to his diagnosis, John was healthy, bright, and was active in sports. And after diagnosis and treatment, he struggled with balance, coordination, along with speech being affected. When he completed all of his treatment, he was unable to return to school, but he was thin and frail, and for a long time required a wheelchair to help him get around and extra support to help him learn. Keeping up with schoolwork is difficult, and balance and coordination continue to be an issue, particularly during break and PE at school. Fortunately, John is cured of his brain tumour, and despite his many challenges, with perseverance and hard work, he is hopeful he will complete school and secure a place in college. Today, John struggles with other effects related to his treatment, including cognitive defects, short stature, hearing loss, hypothyroidism, and thinning hair, all of which are lifelong challenges. He also remains at risk for additional problems such as osteoporosis, cataracts, infertility, renal problems, and secondary cancers as he goes on to navigate adulthood. You can see from this short case study the effects of a childhood cancer treatment can have. We need to be mindful that not everyone will be affected the same way, and there are risks that predispose you to these late effects. The risk factors. Well, first and foremost, children are at more risk of side effects than adults, and this is because their bones and tissues are growing rapidly, and cancer treatment can interfere with this critical time of growth. And there are many different factors that increase the risk of late effects, and I'll go through a few of them. I'm going to go through them in relation to the case study to sort of put a more human perspective on it. So John required radiation as part of his therapy, and the dose and the fraction size and the organ that was irradiated will all impact what sort of side effect there'll be. So we know from the case study that he had short stature, his growth had been affected, and also his hair was thinning, and that was due to it never grew back properly from the radiotherapy field. Chemotherapy. He had high dose chemotherapy, and this was a platinum based chemotherapy, and his hearing was affected. And we know that this type of chemotherapy can affect the kidneys as well. So it remains to be seen in the future, will he have renal problems as well? Surgery, the site and type of surgery. So John had a surgery to his brain, and this is very high risk. Any sort of brain surgery is high risk. So he did have a posterior fossa syndrome following the surgery, which has improved, but his balance, coordination, and speech were significantly affected. There was a combination of treatments, so this was very intensive high treatment. So the risk of side effects are much greater. He also had autologous hematopoietic stem cells reinfused, and we know that these have significant short and long-term side effects. The ones that affected him most were particularly to do with his gut, and it took a long time for that to resolve. Other related factors, age at diagnosis. He was 10, he was still growing, and that was a very important part of his development, and that was affected. Developmental status, he was pre-pubertal, so it's likely that he will be infertile, but that goes on, it remains to be seen until he's older. Genetic disposition, although he didn't have any syndromes, sometimes if children have syndromes, it predisposes them to secondary cancers more than others. Socioeconomic status, this is more to do with his follow-up rather than his actual treatment, in that in order to have the resources to access appropriate treatment as required, and the knowledge to navigate the system. So depending on your socioeconomic group, you are at an advantage or a disadvantage. And then healthy lifestyle choices going on to, as I mentioned earlier, behaving in high risk lifestyle, such as smoking, drinking, etc. And we know that there are many risks associated with late effects, and that these children need long-term follow-up. So where are we with long-term follow-up? So the past. In the 50s and 60s, cancer survival was poor. Treatment was focused on a cure, and there was little focus on late effects. As treatment became more intensive, there was an idea that the more treatment you got, it was the better. But we saw that survivors were doing better, but they were also, as they were living longer, they were experiencing a multitude of issues. And this is where clinical trials started to evolve. So this brings us on to the present. Many decades of research and clinical trials has led to the classification of children's cancer at diagnosis and identifying the treatment that is most likely to cure them with the least long-term damage. And this is ongoing research. there is an increased national and international awareness that childhood cancer treatment causes long-term side effects and impacts quality of life for the survivors. And there's many international groups now looking at this. There's progress in the area. Nationally, the National Cancer Control Programme has recognised that cancer survivors have specific needs and have carried out comprehensive needs assessment and have issued recommendations which are being implemented. There's a fertility programme now up and running between the Marion Fertility Clinic, CHI Crumlin and the Irish Cancer Society, addressing the fertility needs of cancer patients and survivors. However, by and large, at the moment in Ireland, the service for this group is fragmented and really relies on the vigilance of the treating consultant. And the future, what does the future look like for this group? Well, it's recommended internationally, and this is aligned with the NCCP recommendations, that there is a coordinated transition from child to adult follow-up service, considering the medical, psychosocial, educational and vocational needs of CAYA cancer survivors. Okay, we know from international research, as mentioned, that by considering the holistic needs of childhood cancer survivors in a structured way, we improve long-term health of these survivors. Existing late effects are managed better. There is surveillance for potential future complications. Through monitoring, it's easier to prevent illness and to treat advanced cases. It's more cost effective. Information is available for survivors, families and carers. Healthy lifestyle choices are promoted, and overall you get better engagement from the survivor. What does this service look like? Well, it should have a multidisciplinary team approach, access to appropriate service, doctors with experience in late effects with the knowledge and expertise in the area, specialist nurses caring and supporting while adhering to best practice, other health and social care professionals, psychology, social work, speech and language, occupational therapy, coordination of care, a person to coordinate appointments and hospital visits. And we know that this encourages compliance and better engagement by the survivors. A comprehensive treatment summary of past medical history and treatment received, individual survivorship care plan, mapping out risks and appropriate surveillance, education and information for survivors, family and non-specialists, so that they can access the appropriate services. And overall, a service that is accessible and supports self-management. So in summary, CAYA cancer survivors are vulnerable to a variety of long-term treatment-related side effects. And with established evidence-based follow-up care for early detection and treatment of late-onset complications, we can help this cohort reach their physical, emotional, and social potential. It's really important that we get this right. Not only do they have a much longer life expectancy now, we want them to grow up to be important members of society. And now that this service is being developed and it's poised for success, things are looking brighter for this group. And instead of trying to push up the hill to get where they want to go, back.
Okay, Elaine. Sorry, is that it?
Yeah, it's just I just want to say, if anybody has been affected by any of the issues discussed and have any further queries or require support or would like to speak to one of our cancer nurses or be referred to one of the trained parent volunteers, please call the Cancer Nurse Line on 1-800-200-700 and or email cancernurseline@irishcancer.ie.
Great. Thank you so much, Elaine, and thank you so much for that wonderful presentation. I just have a few questions for you, if that's okay.
Okay.
So the first question would be that if I was worried about long-term side effects with my child, where should I go for follow-up care? What should I do about that?
Well, at the moment, it's only being developed. So if you are concerned, I would go back to your treating consultant and talk to them in detail about your concerns. Now, there are some very good sites that have information on long-term side effects. There's PanCare Europe, and I have references at the end that I can share. And the harmonisation group, the UK CCLG, also have very good information on late effects if you have any concerns. And obviously, I'm very willing to talk to anybody if they would like to talk to somebody in confidence as well.
Okay. And how are children followed up if they're 18 or over? Is that through adult hospital settings?
Yeah, at the moment, once they get to a certain age, they are transferred to an adult service, and at the moment they would be sent back to their referring hospital. So the service is fragmented at the moment. It's not structured, but in the future, that is what we're hoping for, and we're very happy that there's work being done in that area through the NCCP.
Okay. And we have a question here. How do you know if it is a late effect or another condition like aging or genetics?
Well, we know that there are a lot of side effects to cancer treatment, and if you have had treatment in the future or in the past, it's very important whatever doctor you are going to is aware of that and taking it into consideration. I mean, you're right, lots of people will get things along the way that are just normal, but sometimes these are very specific, and if they know what they should be looking out for, it can be a good guide going forward.
Okay. We have a question from, I think, a gentleman in Scotland, it would seem, and I'm not sure if you'd know the answer to this, but we will ask it. I'll ask it. Do you know of any late effects clinics in Glasgow or Argyll or the Bute area?
I don't know off the top of my head, but I do know there are consultants over there that are very active in the late effects world. So I am sure there are. I can have a little, I'll do a bit of research and I can find out.
Oh, great. Thank you, Elaine. And as I say, if you contact our support line, our nurses on our support line, we can connect them up or collect that gentleman up with us in that information. And the question here as well from Patricia, what is the timeline for the delivery of the recommendations for the NCCP?
I don't want to give a timeline because it has been delayed already through COVID, but I'm very willing to try and find out and talk to her offline.
Okay, thank you. And just to qualify, Pat Hayes is the woman. So not Patrick, perhaps Patrice or something else like that. So my apologies. And I think, as far as I can see, that's the questions. And just to reiterate, of course, to contact us on our cancer support line, 1-800-200-700, or indeed on cancer.ie. And just for people to know, we have your good self, Elaine, as our childhood cancer coordinator, and we have 5 wonderful parent peer volunteers, trained, ready, and just delighted to talk and listen to any other parents going through something similar. So with that, thanks so much, Elaine, for that. Well done, and I hope everybody enjoys what's left of our conference. Thanks, everyone.
You're very welcome. Bye-bye.